Thank you very much again for agreeing to serve as committee members for my thesis examination today. It's my great honor to present my thesis entitled Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. And my principal advisor is Ajahn Sarinya Puvanan. The outline that I would like to cover today includes introduction and literature review, depth of knowledge, research methodology, results and discussion, and conclusion. Firstly, I will start off with the introduction and literature review. Heart failure is a common condition which is a big problem worldwide. The prevalence of heart failure in general population is 1 to 3%. It means that over 240 million people were living with heart failure in 2022. If you look at the mortality, you could see that over half of heart failure patients die within 5 years. The annual healthcare cost for heart failure is up to 25,000 euro or over 900,000 Thai baht per year. Let's take a look in Asia. This figure shows the prevalence of heart failure in Asian countries. We could see that heart failure is prevalent in Vietnam and Thailand, with the number around 6 to 700 per 100,000 people. More detail in this figure with the crude mortality of heart failure at first year. In Vietnam, one-fourth uh, one-fourth patient with heart failure die in the first year, and this number in Thailand is one-fifth. It means that the one-year mortality is very high in heart failure patients, especially in Southeast Asia. As you may know that heart failure is a big problem. So let's move on to the classifications of heart failure. Heart failure can be classified into three types. Heart failure with preserved ejection fraction or HFpEF. Heart failure with mildly reduced ejection fraction or HFmrEF. And heart failure with reduced ejection fraction or HFrEF. HFpEF is defined as the presence of symptoms and signs of heart failure plus LVEF equal or greater than 50% plus evidence of cardiac structural and/or functional abnormalities addressed or with exercise. The definition of heart failure of HFmrEF is similar to HFpEF except for LVEF is in between 40 and 50%. Let's take a closer look at HFpEF and HFmrEF. This figure shows the trend in prevalence of heart failure by gender. The vertical axis shows the prevalence of show the prevalence in percentage, and x-axis present age group. Comparing the trend of HFpEF and HFrEF, we could see that the prevalence of HFpEF increased much greater than HFrEF by age, especially in female, implying a greater burden of HFpEF in heart failure population. In this cohort, you could see that more than half of patients with HFpEF and HFmrEF. The 5-year mortality rate of those patients were not different from the patients with HFrEF. And again, 5-year mortality rate in this cohort was 75%, and the mortality in readmission was up to 97%. One of the most common problems of HFpEF and HFmrEF is exercise intolerance. Let's go further on it. So what is exercise intolerance? It is defined as a complex clinical syndrome represented with reduce oxygen consumption of VO2 during physiological stimulation. VO2 could be affected by cardiovascular, pulmonary, and muscle structure and function. How to measure VO2? We use cardiopulmonary exercise test. It's a comprehensive test for measuring it. During the test, the work rate will be incremental and the peak oxygen consumption is determined as the highest VO2 achieved when patients reach maximum effort during the test. Peak oxygen consumption is considered normal when it is equal or greater than 85% of the predicted value or greater than 20 milliliters per kilogram per minute. Let's take a look deeper in the pathophysiological abnormalities contribute to the clinical manifestations of HFpEF. Risk factors such as multi-morbidity, aging, obesity, physical inactivity, and systemic inflammation lead to downstream of multi-organ dysfunction, frailty, cardiac dysfunction, and skeletal myopathy, resulting in respiratory muscle weakness and exercise intolerance. The mechanism of respiratory muscle weakness could be explained by some mechanisms like respiratory muscle atrophy, change in muscle fiber size, muscle metabolic reflex, reduced oxidative capacity, ventilation inefficiency, and physical deconditioning. So, the previous sections, you could see that respiratory muscle weakness is a key contributor of exercise. Let's further explore the status of inspiratory muscle weakness in HFpEF. The prevalence of inspiratory muscle weakness in HFpEF is 30 to 40%, and inspiratory muscle weakness is defined as maximal inspiratory pressure, or MIP, less than 70% of the predicted value. MIP test is a measurement used to assess the strength and function of the inspiratory muscle, particularly the diaphragm. In clinical practice, inspiratory muscle weakness is considered as a poor prognostic factor in heart failure. This figure presented the survival rate of heart failure patients with and without the inspiratory muscle weakness. So the red lines show the patients with inspiratory muscle weakness. You could see that patients with inspiratory muscle weakness had a significantly lower survival rate than those without inspiratory muscle weakness in both HFrEF and HFpEF. So, what is the solution for inspiratory muscle weakness? An effective way to strengthen respiratory muscle in patients with HFpEF is respiratory muscle training. In this method, inspiratory muscle training with resistance training is a great concern because inspiration is generally an active progress of diaphragm activities, and it plays a vital role in in oxygen uptake efficacy. In addition, the resistance training device is user-friendly and more cost-effective than other devices. So while the patients train with inspire muscle, the IMT trainer will provide a stable resistance while inhalation, and the patient need to inhale strong enough to get over the threshold. So how IMT could improve functional capacity? IMT directly strengthens the respiratory muscle, including the diaphragm and the intercostal muscles. By that way, IMT improves the pulmonary function, which is one of the most important factors to increase peak oxygen consumption, as I told you. And it means that functional capacity will be improved. In order to gain an expected outcome, the IMT program will be set based on three components: duration, frequency, and the intensity. The intensity depends on the percentage of, of MIP and divided to high intensity, moderate intensity, and low intensity. An appropriate intensity is very important to optimize the outcome. For example, patients with HFpEF have higher functional capacity compared to HFrEF, so they need to train at higher intensity. Until now, only two trials were performed to evaluate the efficacy of IMT in HFpEF, but both studies used low to moderate intensity of IMT. In addition, they used unblinded trial and small sample size and lack of report of compliance to home-based IMT program. And an interesting finding is no previous study evaluated effects of IMT in HF and REF patients. So the gap of knowledge is that there have been no study conducted to evaluate the effects and safety of high-intensity IMT on patients with heart failure who have mildly reduced and preserved ejection fraction. So we conduct this study with two objectives. Firstly, the study is to evaluate the effects of home-based high-intensity IMT program on an increase in peak oxygen consumption from baseline in patients with HF and REF and HFpEF. And secondary objectives are to evaluate the safety and effectiveness of home-based high-intensity IMT program on improvement of MIP, 6-minute walk distance, and quality of life, and echocardiographic diastolic parameters. Patients with HF and REF and HFpEF will present with impaired muscle weakness, which is also affected by other factors such as aging, nutritional deficiency, obesity, medications, and comorbidities. IMT will have to increase the strength and speed of shortening, power output, and endurance of inspirator muscle. By that way, IMT could improve peak oxygen consumption and some secondary outcome. I have just explained the reason why I look forward to conducting this research. Now I will proceed with clarifying the method for undertaking it. Firstly, the study design. We perform a randomized controlled trial and I will include the patients with diagnosis of HFmREF and HFpEF in the medical records who have age greater than 18, NYHA class 2 or 3, and patients with a stable dose of heart failure medication within 4 weeks. To ensure the randomness and blindness, we used block randomization method with a block of 4 and 6 in 1:1 ratios in the two groups. And all outcome measurement and data analysis researchers are blinded to the patient's allocation groups, and patients are also are blinded to one another in the measure. The intervention protocol. The high-intensity IMT group will be performed with a warm-up in 5 minutes. Training will be set with 10 repetitions, 5 sets of 10 repetitions. And the resistance will be set at the first week of 30% MIP and increase to 50% MIP in the second week and 70% MIP from the third week. And the sham IMP will be the same training with the training resistance keep instance on 15% of MIP. Yes, this is the IMT device. We use a threshold device, power breath classic like resistance, and it includes 11 adjustable levels. This is my study endpoint. The primary endpoint is the change in peak oxygen consumption at 8 weeks, and the secondary endpoints is the change at 8 weeks of MIP, 6-minute walk distance, quality of life, echocardiographic diastolic parameters, and some safety outcomes. To manage patients' compliance, uh, we use some ways to include a logbook, phone calls, and checklists. Here is the data collection plan. From the admission to the end of intervention, I will collect all of this data during the first meeting when patients are eligible for the study. Additionally, they will be taught the training program prior, the, prior to the study by physiotherapists. The sample size calculation. We set the power of study at 80% and alpha level at 0.05. The results show that we need 34 patients in each group, and we assume that 15% of patients will drop out of the study. The total number of participants is 40. The statistical analysis, intention to treat analysis was considered. The data will be reported as percentage or mean and SD. The independent t-test will be used for two groups, continuous data and normal distributed, and chi-square test will be used for categorical data. In addition, linear mixed model was used for longitudinal analysis of MIP, and p-value is less than 0.05. For the ethical issues, the cardiac rehabilitation is not implemented as a mandatory routine in Vinmec International Hospital, so comparing a high-intensity IMT program with a sham control allows for fair comparison to user care, both while ensuring a non-biased and blinded study design. We also provide consent form for all participants, and participants can withdraw from the research at any time. The study protocol also was approved by Chulalongkorn University IRB and the ERC of Human Healthcare System. Here's my study timeline. I need 1 year for achieving IRB approval, both in Thailand and in Vietnam. And I have submitted my paper last month. And this is my recruitment flow. I have screen, interview, ask for consent form, and give the patients the randomized envelope. All the patients I have screened in heart failure outpatients clinic. And finally, I could go through the results and discussion section. So the total of 72 patients was screened, and 32 of them was excluded. 40 patients was randomized and stratified by instrumental weakness to high density or sham IMT group, and all of them was follow up and analyze the data. The results as baseline. You can see that all parameters are similar among groups, which shows that two groups were assigned quite equally. Most of patients' features are similar to previous study, except for the proportion of female. Here in my study, just 38% of female. It is lower than previous study in HEPF. In the literature, female was often predominant in HEPF, with the proportion around 50 to 62%. But some studies also show the predominance of male. The deviation could be due to the differences in the age groups of HFpEF patients. The lower age, the lower proportion of females. We also compare the patients with and without inspiral muscle weakness. There are 35 patients, 35% of patients have inspiral muscle weakness. You could see that average strength reservoir, VO2 peak, and 6-minute walk distance are greater in patients without inspiral muscle weakness. The result gave me an idea to explore deeper in the relationship between inspiral muscle strength and other outcomes. When I perform the univariate analysis, I see high correlation between MIP and VO2 peak and 6-minute walk distance and average strength reservoir and age. It is aligned with previous study. In multivariate analysis adjusting for some clinical and demographic covariates, MIP demonstrated significant positive correlations with key parameters of exercise capacity, including VO2 peak and 6-minute walk distance. It could strengthen the theory that MIP is an independent indicator of exercise capacity, and increasing MIP will improve exercise tolerance in heart failure patients. In contrast, the correlation between average strength reservoir and MIP is significant in univariate but not in multivariate regression. It may reflect the impact of confounding factors such as age, sex, and comorbidities to the relationship. The main section of the study will explore the effectiveness of IMT in the patients with HFpEF. For the primary outcome, the results show a meaningful difference between groups. The mean change is 1.5 milliliter per kilogram per min, which is greater than minimal clinical important difference or MCID of VO2 peak, which is which is only 1 milliliter per kilogram per min. From the previous literature, the changes in VO2 peak of moderate intensity IMT in HFpEF is around 2.8 after 12 weeks and 2.2 after 24 weeks. The lower improvement in our study could be due to a shorter duration. The results of 6-minute walk distance is similar to VO2 peak with a change of 38 meter after 8 weeks is significant and exceeds the MCID in heart failure patients. While performing longitudinal analysis for MIP in multiple time points, the vertical line shows the number of MIP and axis shows the time points. Both groups show an increase in MIP, particularly between week 0 and week 4. The high-intensity IMT group exhibit a consistently higher rate of improvement compared to the control group at the time point. This pattern of improvement could be explained by the change of muscle with the resistance training is often significant in some first week and stabilize after that. In more detail, this table presents the post-hoc analysis from the mixed model comparing MIP between groups at different time points. You could see that they were not significant different at baseline until the week 2. However, at the week 4 and week 8, the difference becomes significant with the p-value decreases. The results suggest that high-intensity IMT lead to a greater improvement in MIP over time compared to the control group. IMT will directly strengthen the inspire muscle, so all previous study indicated the improvement after training, but they only compare at 2 time points. The progressive improvement of MIP in our study showed the superiority of high-intensity IMT over time compared to the sham IMT. For the heart function by echocardiography, three parameters in the table is often used for assessing diastolic function. In our study, only airstream reservoir show a significant difference in mean change between groups. Airstream reservoir is becoming a reliable prognostic marker in HFpEF. A recent study short a recent study reported that a 5% decrease in airstream reservoir is associated with a 30% increase in the risk of severe cardiovascular death and heart failure hospitalization. The increase of 2.4% in airstream reservoir in our study, aligned with the previous study, contribute to the improvement of overall outcome in HFpEF. For quality of life outcome, IMT show varied results in quality of life in heart failure patients. Some studies also reported no significant change in quality of life in patients after 8 weeks of moderate intensity. But in our study, 2 domains show significant improvement, including role functioning, physical, and general mental health. It could be due to the psychological effect of exercise have the patient feel better in their daily life. Our study also showed a positive number of adherents, with the average session attend is over 47, and the rate after adjusting for medical leave is around 98 to 99%. Finally, and fortunately, no adverse events were reported throughout the training program, both in high intensity or sham IMT. After all, because of the time frame of the PhD program, our study has some limitations. Firstly, a relatively small sample size that might have reduced statistical power. The 8-week intervention duration might have been insufficient to detect substantial changes. The lack of long-term follow-up leaves the sustainability of benefits uncertain. So the conclusion are: firstly, high-intensity inspire muscle training is a safe and effective intervention for improving outcome in HFpEF and HFmrEF. Secondly, further research with larger sample size and longer follow-up periods is recommended to validate these results and explore the long-term benefits of high-density IMT. Thank you very much for your attention. I really look forward to receive your suggestions to have improved my thesis. Thank you very much again.